Okay, folks, I think we have a quorum. We have about 18 people on, so we'll get started. So thanks for joining us once again. Again, a reminder not to use any private health information in discussion of your cases. This morning, I'll be facilitating as usual. We're very pleased to have Dr. Neeland with us this morning. We'll be talking about novel or newer ways to assess cardiovascular risk. Ian and I work together in many different contexts, mostly in submitting grants and working in the cinema program here at University Hospitals. Our presenters today will be Dr. Healy, and I will be presenting Erin's case. Unfortunately, she was not able to join us today, and so we'll do the best we can. I think having read through her case, I think that there's just so many interesting questions to address. We'll have to get organized as we go through the details of it. Next slide, please. These are your usual reminders about assistance. Next slide. And these are our disclosures with no changes from last week. Next slide, please. And again, basic recommendations about using patient-centered language. As I say every week, it takes a little bit of practice. Okay, Ian, the floor is yours, and thanks again for coming to join us this morning.
Well, thank you for having me today. It's a pleasure to speak with the group here for Cardio and the ECHO program. Very excited to speak with you. So we'll discuss for the next several minutes methods for assessing cardiovascular risk. And my goal really is to give a broad overview of our approach in cardiology as a preventive cardiologist towards assessing cardiovascular risk in patients. But this is definitely something you can apply across the primary care spectrum for all patients who come to see you. Next slide, please. So there's 3 learning objectives today. We'll discuss the use of coronary calcium scoring for identifying cardiovascular risk. This is probably one of the most prevalent and powerful tools we have for risk prediction in cardiology. We'll list and describe several novel emerging cardiovascular markers and their potential use in primary care, and then describe some newer methods for assessing cardiovascular risk, or at least touching upon the concept of assessing cardiovascular risk in minority populations. Next slide, please. So to think about risk in the cardiovascular context, one has to understand that there's really a timeline of risk. And whenever a patient comes to your office to discuss this risk concept, you really have to understand where they are in terms of this timeline. Now, predisposition to disease really starts prior to birth, right? There are genetic and epigenetic and environmental factors that impact one's predisposition to cardiovascular disease many, many years down the line. One example of this would be maternal preeclampsia, for example, or low birth weight. Those type of issues that have been connected with cardiovascular issues in adulthood. And then once a person is born and they start growing up, then we kind of look at them in the sense of a healthy person in most situations, and whether they're in the disease-free state. But even though they're disease-free, they're certainly at risk in the future for developing cardiovascular disease. This is why we do screening for children in many cases for high cholesterol, for example, to identify those with familial hypercholesterolemia or severe hypercholesterolemia. And so in the disease-free state, really one has a genetic predisposition from their family. It's a non-modifiable risk factor that we'll discuss. And the environmental and behavioral aspects play into what's called primordial prevention. And then we get into the preclinical disease stage, which is mostly what we're familiar with in terms of risk assessment or risk prediction. And that's where someone may have some subclinical findings, for example, coronary calcium that is present, or risk factors that really playing a role in subclinical disease, yet the person has not yet had a clinical event, such as a myocardial infarction or a stroke. And then you get into clinical disease, which is secondary prevention, where a person has already had an event, and then we're trying to prevent a subsequent event. And at each stage of that timeline, there are different ways to think about the patient's risk, different screening tools and interventions we would take. Next slide, please. So I think this is known to all of us here. There are the traditional atherosclerotic cardiovascular disease risk factors. We will have both non-modifiable and modifiable risk factors. Obviously, age continues to be a risk factor as long as you're alive. So does biological sex, race, and family history. And those are all things that we come with as people that are not modifiable, but do play a role into our assessment for risk. And then we have the risk factors that we routinely screen for and try to treat in terms of reducing risk. And that's high cholesterol, smoking, high blood pressure, diabetes, obesity, alcohol use or excessive alcohol use, and physical inactivity, which is certainly rampant in today's day and age. Next slide, please. The most important concept to think about in 2022 for risk prediction or risk assessment for cardiovascular disease is the pooled cohort equations risk calculator. This is the foundation and the first step of what we now do in preventive cardiology in terms of risk assessment when we're looking at someone for primary prevention who have not yet had a myocardial infarction, stroke, and have not had sudden cardiac death. Now, the pooled cohort equations risk calculator was developed, I think it was put out in 2013 as an iteration that improving upon the Framingham risk score, which came out in the late 90s. And the idea here was to not just look at one cohort, the Framingham cohort, but actually combine and pool multiple cohorts that was potentially more representative of the general US population, both with kind of updated, newer epidemiology as well as race and ethnicity. So the factors that go into our pooled cohort equations risk calculator, which essentially gives you the probabilistic 10-year risk for atherosclerotic cardiovascular disease, is age, sex, race, and here the race is either Black or white. So if it's not one of those two, they usually go into the white category because there's not enough data for other race ethnicities out there for this equation. Total cholesterol, HDL cholesterol, systolic blood pressure, and then the presence or absence of hypertension, diabetes, and smoking. So this is what goes into the risk calculator. And as you can see, when we do this, and this is available online and app-based as well, you get a 10-year ASCVD risk. And based upon that, as we determine then whether you are low risk, intermediate risk, or high risk. And essentially that's where the first step and where we start with risk prediction in the office. Next slide, please. Now, it's important to know that the PCE, the pooled cohort equations, may overestimate risk in some and underestimate risk in others. This had been an initial observation, even when the pooled cohort equations were first identified and were shown in the American College of Cardiology back in 2013 meeting. And there were data already that showed that in many individuals, that compared with prior recommendations, there are many more, thousands or hundreds of thousands, potentially millions of people who will be on statins based upon this. But there's also data out there, studies that I've worked with as well, that may underestimate risk in certain populations. For example, patients with severe obesity, patients with HIV disease, and such. So this is not the end all be all, but it is the first step. Next slide, please. And that being the case, we require sometimes additional testing to refine our risk assessment. Now, it's important to recognize that the imprecision of CVD risk prediction and the uncertainty clinicians and patients may encounter regarding potential benefits of drug therapy, that's really where we start to have this patient-doctor discussion and shared decision-making. And so really the action is at the borderline or intermediate risk, right? Because you can imagine if someone is extremely low risk, then there's very little benefit likely in initiating preventive therapies with potential side effects. And if someone is very high risk, then the benefit usually outweighs any potential risk. But it's at that borderline or intermediate 10-year ASCVD risk, which itself is a little bit of a moving target, whether we're talking about 5 to 7.5%, 7.5% to 10%, or to 20% ASCVD risk over 10 years is still questionable. But in that borderline intermediate range, that's where additional testing may be useful. So in general, over the past decade plus, it's really been understood that the identification of actual subclinical atherosclerosis, rather than the use of other biomarkers from the blood, is preferred, because there's an extensive body of evidence that shows the utility of atherosclerosis disease assessment when you're doing risk prediction, particularly with subclinical athero from coronary calcium measurement, really beats out and is more it's more discriminatory, and it's also calibrated for any serum biomarker for the prediction of future ASCVD events. And so really other modalities that many of us have probably seen before, have used, and are certainly prevalent in the community. Patients will bring you, reports of these community screenings that include carotid intimal media thickness, carotid plaque burden assessment. They're really much weaker predictors compared with coronary calcium scoring, and generally not useful. And I'll show you some data why that is. Next slide, please. So let's talk about our first learning objective, discussing the use of coronary calcium scoring for identifying cardiovascular risk. Next slide. Calcium scoring, many of you probably are familiar with it. Here at university hospitals, there's a no-charge calcium scoring program that has been around for several years. And so, we have a registry of patients, of many thousands of patients who have coronary calcium scoring, a very powerful database. Calcium scoring actually started in 1992 with a business, essentially, called Heart Check America, that initiated scanners in Chicago and LA, and tried to sell people, essentially, these risk assessments with calcium scoring. And that has now evolved over many years, first in MESA, which is a large NHLBI-funded cohort of multi-center cohort in 2000, as well as the Rotterdam study overseas, and then Heinz Nixdorf recall study also in Europe, that included coronary calcium scoring in their epidemiologic cohorts. And when we have longitudinal data going back, many years, looking at the associations between coronary calcium scoring and different outcomes and disease phenotypes. And it's also important to note that the initial calcium scores were done with EBCT, electron beam CT scanning, and now currently they're done with newer generation scanners, multi-detector or MDCT. It's about 1 millisievert of radiation that you get, which is essentially what you would have if you went over a transatlantic flight. So it's very minimal radiation. There is no contrast dye involved in coronary calcium scoring, which is important as well. And it's a very brief scan. And what you get is cross-sectional images of the heart, as you would of any CT scan, identifying calcification in the coronary arterial bed. And this can be quantified as a score in Agatston units, because Agatston, from diet book fame, was one of the first to kind of describe this score. And the higher the score, the greater the risk, as we'll see. Next slide, please. So you can start here, one more, yep. We can start here showing you three different kind of situations where you might have one small speck of calcium there in the coronary artery. The second picture shows you a little bit more, and then the third, obviously, much of the artery is laden with calcium burden. And again, this is quantified as a score by the radiologist or cardiologist reading the study. Next slide, please. The first study to show really a major impact of coronary calcium scoring on risk assessment was the DeTrano study in New England Journal. It's been cited over 2,400 times per Google Scholar. And this really showed that in this cohort, there was a good risk gradient. If one had 0 calcium versus 1 to 100, 101 to 300, and over 300. So you can see here that both for a major coronary artery disease event, MI, and death from heart disease, as well as for any coronary artery event, there was a risk gradient going from, compared with 0, going from 3 to 7, and higher to a hazard ratio for a coronary disease event. And, very highly statistically significant, a large population cohort of over, several thousand people. And this was really the first time that people understood that this could be used as a risk prediction tool. Next slide, please. And this shows you how understanding or incorporating coronary calcium can enhance one's risk assessment from, for example, the Framingham cohort. So here you have total coronary heart disease events on the left, and hard coronary heart disease events, that's MI and stroke and cardiovascular death on the right. And what you can see is that if you would just take into account the Framingham risk score, going from 0 to 6%, 6 to 10, 10 to 20, and over 20, one would potentially not have all the information or underestimate potential risk in many individuals and overestimate it in others. But if you add and layer in coronary calcium scoring, you can stratify those individuals within each risk category from the prediction calculator to be more refined and more precise with one's risk. In fact, if you're looking at a Framingham risk score of over 20%, for example, for total CHD, you can see there a CAC score of 0 has an event rate associated with it of 2.5 per 100 patient years, whereas a CAC score of over 300 is 15-fold, 33 event rate per 1,000 person years. So again, you can see it really stratifies risk to a substantial degree, and something that can really help us understand and counsel patients on what their actual risk for heart disease would be. Next slide, please.
Ian, could you just clarify what's the difference between hard and total CHD? What's hard CHD?
Hard CHD is usually defined as MI or cardiovascular death, and total is usually adding in there revascularization or other events.
So it's MACE kind of thing. Okay.
Yeah. Now, this slide is from Joseph Yaboa, who was at Wake Forest and was in JAMA in 2012. And I like this because it compares the risk scoring alone, in this case it's Framingham risk scoring, with several of the risk tests we see commonly in primary care clinical practice. So it's comparing the risk discrimination for ASCVD, atherosclerotic cardiovascular disease, comparing Framingham alone versus Framingham plus coronary calcium, Framingham plus carotid IMT, intermedial thickness, Framingham plus FMD, which is a measure of vascular relaxation, dilation using brachial artery ultrasound, Framingham plus CRP, C-reactive protein, Framingham plus family history, that's FH, and then Framingham plus the ABI, the ankle brachial index. And I think this illustrates it very nicely because you see that all the curves are essentially superimposed except for the red one, that one being Framingham plus coronary calcium. And you can see in the area under the curve, or the C statistic, that coronary calcium, the Framingham plus coronary calcium outperforms and improves risk discrimination to a substantial degree beyond any of those other risk tests. And many of those risk tests are no different than this risk prediction score alone. So this is where I think it really shows very clearly that if one's going to pick a risk test to do, in addition to the pooled cohort equation, which is what we use nowadays, as I mentioned, coronary calcium scoring would be the test of choice because it has the most discriminative ability and the biggest ability to move the needle in terms of our understanding of risk beyond any of these other tests. Next slide, please. And so kind of how to understand that in an algorithmic sense, and this is just one recommendation from Phil Greenland, who's at Northwestern, and his colleagues from this paper, how to incorporate and when to incorporate coronary calcium scoring to guide risk prevention therapy for specifically statin initiation. So as I mentioned, in the low-risk population, less than 5%, generally statins are not recommended, right? So it's always a patient and physician decision-making. It's always important to have shared decision-making, but generally the benefits are relatively small in the primary prevention population, not recommended. And therefore, it's probably not effective to do coronary calcium scoring in a very low-risk cohort. Okay, now there are, as I'll show you, there are risk enhancers that one can actually add in to think, well, maybe a coronary calcium score would be important and help me here because the risk is not less than 5%, maybe it's a little bit more, just based on the PCE alone, maybe they're risk enhancing. In the intermediate range, which is that 5 to 20% essentially, where one should consider or recommend a statin based on guidelines, coronary calcium scoring in those individuals who do not want to take a statin, for example, or they're worried about the side effects and they really want to know if the benefit is there for long term, coronary calcium scoring can be helpful because a CAC score of 0 in the intermediate risk population could de-risk an individual to a sufficient degree where you might say, okay, let's hold off on the statin for now, especially if one is very hesitant to do it. Whereas if the calcium score is elevated, then it's a stronger recommendation to recommend the statin for that person who may be on the fence and maybe may need more convincing and understanding of risk. And so that's why reclassification up or down can be very helpful in an intermediate range. And then, as I mentioned, if someone's 10-year risk is over 20%, so statin therapy is recommended per guidelines. And even if one's calcium score is 0, it's possible that the risk is sufficiently elevated that the statin would still be important even in those individuals. But again, it's always a shared decision making. And so in that population, CAC might not be effective for that population. I would say probably the biggest lesson for that population would be, the 70-year-old age bracket and above. I see calcium scores in those individuals quite often. But if one would put, their numbers into the Cohort equation, they would probably be over 20% in many individuals, and a coronary calcium score was probably not effective in that situation. So I think that can be very helpful to kind of help guide how one uses coronary calcium scoring and to understand statin, yes or no. Next slide, please. Okay, so let's talk a little bit about list and describe the novel cardiovascular markers and their potential use in primary care. Go ahead, next slide. So as I mentioned, there are many risk-enhancing factors that we consider beyond the pooled cohort equation and beyond coronary calcium scoring. And many of these are, kind of obvious to the clinician, understanding that these will enhance our risk. And I'm just going to kind of read some of them and make some points. So the family history of premature cardiovascular disease is important and tends to be more important the earlier it occurs. So when the patient has a parent who had a bypass surgery at age 75 is unlikely to fit in this, but a person who had an MI, their father, for example, had an MI at age 42, that's an important data point to consider. And primarily because that will have downstream, potential consequences through lipid abnormalities that are genetic, for example, LP(a), which I'll talk about, or others. Primary hypercholesterolemia, so even if one is young but has very elevated LDL cholesterol of over 190, for example, severe hypercholesterolemia is a risk factor. Metabolic syndrome, chronic kidney disease, chronic inflammatory conditions are all very important, to elevate the risk. History of premature menopause and pregnancy-associated conditions that increase the risk, such as preeclampsia, are very important. I think these are relatively overlooked in many situations because, it occurs in young people for the most part. And so we tend not to consider that cardiovascular risk, but it actually is a risk enhancer. There are higher risk race ethnicity, specifically South Asian ancestry, where individuals can have abnormal dysfunctional adipose tissue even at a low BMI, for example, and so it increased risk. And then several lipid-related biomarkers and others, such as high sensitivity CRP, elevated lipoprotein (a), which essentially is genetically determined, ApoB, and then we talk about ABIs, although ABIs are generally not helpful for risk prediction in addition to the PCE. Next slide, please. So just one moment on advanced lipoprotein testing. So this shows you an individual with the exact same LDL cholesterol, 110 milligrams per deciliter. But if you look at their pattern versus the A pattern and the B pattern, so the A pattern is characterized by 1,200 LDL particles, the actual numbers of particles, an ApoB of 90, and a non-HDL of 130. The exact same LDL of 110 in a B pattern is associated, for example, with a higher LDL particle number, higher ApoB, and a higher non-HDL cholesterol. So the LDL cholesterol content alone is a important risk marker, but the pattern of itself, and especially increased LDL particle numbers, can help to identify and stratify risk further. For example, you could see here in the Kaplan-Meier curve, the cumulative incidence of ASCVD was increased when your LDL particles were greater than your LDL cholesterol, and intermediate with concordant individuals, and when your LDL particle was low when LDL cholesterol was high, then they actually had lower risk than the others. So again, advanced lipoprotein testing can be utilized as one of those risk-enhancing factors, especially LDL particle number. And it's really a case-by-case basis, though, where you would apply that, usually in a person who is at intermediate range, where this is going to help up risk or de-risk or help make the decision be more clear. Next slide, please. And just one moment on lipoprotein(a). There are trials now actually in therapeutics that can lower this substantially, because right now we really don't have anything that does it outside of niacin, which in general is not helpful. And lipoprotein little a is actually a very interesting molecule. It has both prothrombotic and proatherosclerotic properties. So it's not only related potentially causally to atherosclerotic cardiovascular disease, but also thrombosis. And that is vis-a-vis its interesting molecular structure, including plasminogen and creating platelet activation. Now, plasma concentrations are really genetically determined, about 90%. So that's why since we don't have a therapy right now to impact it, this really is a genetic, in a sense, marker or familial marker of elevated risk. And different places use different assays. Some of them use a mass-based assay, others use a concentration-based assay. And the problem is that they really can't convert between them in terms of units. And so you just have to kind of know what's elevated. And values over 50 milligrams per deciliter or 125 nanomoles per liter are considered usually elevated. And there's also racial and ethnic variation. About 20% of the population has an elevated LP little a, and Black individuals usually have higher levels than white individuals, whereas in the Blacks usually actually have lower triglycerides, for example, than white. So there is variation in lipids. And the graph on the right just shows you that there is an increasing odds for coronary heart disease with variant alleles of LP little a. So one who has over 2 or more variant alleles has about a 4-fold higher odds of coronary heart disease than one with 0 variant alleles. So again, you can see that very tight genetic control. Next slide, please. Okay, so we'll kind of wrap up here. And this is a nice perspective about how to understand risk-enhancing factors, because it's always exciting and I think interesting to say, okay, what can we look for and see if your risk is elevated? Or do you have this? Do you have that? And the issue I think still exists is that although risk-enhancing factors are to be considered and are part of the guideline, it really is important to consider them in the context of a validated model. And right now, we really don't have validated models outside of coronary calcium scoring and maybe high sensitivity CRP. And so the editorialist here for this article said that it's possible that using a risk-enhancing factor, or many of them, can erroneously stack the deck in favor of higher risk and overestimate or overvalue the information provided. So there is a note of caution there when using these factors. And so I think what they recommend is currently rely primarily on the PCE, a risk calculator for primary prevention decisions. And I would add with coronary calcium scoring if applicable, whereas these other risk factors are really taken on a case-by-case basis in certain situations where they may be helpful. And there's always preventive cardiology that you could ask and get some further kind of insight and guidance there. Next slide, please. Okay, so let's take the last moments to describe newer methods or concepts regarding cardiovascular risk in minority populations. Next slide. There are several statements out there and studies looking at variation in cardiovascular risk and the application of risk assessment in minority populations. And at this point, we don't have anything beyond the PCE that includes a differentiation between white and Black individuals. But there's really nothing that we use on a day-to-day basis that we have been shown to have increasing discriminatory value for risk prediction in different race ethnicities. And I think it's just important to recognize, for example, the scientific statement that came out a few years ago from Mercy Carnathan, that the higher prevalence of traditional cardiovascular risk factors does underlie relatively earlier age of onset for cardiovascular disease among African Americans. And therefore, it's very important just to understand that context, even though we may not have risk tests or different risk tests that should be applied to one race ethnicity than another, but the concept that there is variation in higher risk individual populations is out there is important. And this has been shown, for example, in differences in cardiovascular biomarkers in the general population, reflecting differences in lipids, adipokines, and other markers of inflammation, for example, between white and Black individuals. And there's also this study from relatively new in this past year, suggesting that the PCE could generate substantially divergent cardiovascular risk estimates for Black versus white individuals with identical risk profiles. And again, introducing race-related variations in clinical recommendations is possible, but we're not there yet. And so right now, just understanding that certain populations may be at higher risk, especially the African-American population, is probably what I would say is the most important. Next slide, please. And that's it for today. Thank you very much, and be happy to answer any questions before we get to the case discussion.
Thank you so much, Ian. Great presentation. I just had one question and we'll kind of throw it open. You didn't mention LDL particle size and how smaller particles are more atherogenic. Is that related to LDL particle number? Because with a certain concentration, you get more particles, so they must be smaller.
Yes, yeah. So I can point that out. If you want to put the slide back up, I can point that out on the slide in the graphical sense. But the greater particle number is with the same cholesterol content will essentially show they're smaller particles. So go back a couple more. Right there, yeah. So you can see in that graphic, for every 1 deciliter, right, you have on the left, several larger particles with the same cholesterol content. On the right, you have many smaller particles with the same cholesterol content. So that's essentially correct. The smaller, denser particles is a pattern B with higher LDL particle number and smaller.
So in theory, you could have a lower LDL total concentration with small particles that could be more atherogenic than a higher LDL cholesterol.
That's correct. And that's what that graph on the right shows, is that even in individuals with normal, quote unquote, LDL cholesterol, but a high LDL particle number actually may import greater risk.
Thank you. Any additional questions?
Ian, this is Debbie Gordish. I have a question. So
in individuals with normal, quote unquote, LDL cholesterol, but a high LDL particle number actually may import greater risk.
Thank you. Any additional questions?
Ian, this is Debbie Gordish. I have a question also on the advanced lipoprotein testing. Patients frequently ask for it, but very infrequently do I act on it if it's abnormal, because I don't know of any medications, like you said, other than niacin that might have an effect. Are there any known dietary changes that we could at least counsel patients on then?
So for lipoprotein a, there are no dietary changes that really impact that. It's about 90% genetically determined. And the 2 medications that may lower it, or we have now available, will be niacin, as I mentioned, but also PCSK9 inhibitors can decrease it by about 20 to 25%, although it's unclear if that actually is enough to impact risk for Lp(a) beyond the LDL cholesterol, for example. Unfortunately for that, no. For ApoB, yes. ApoB is similar to LDL cholesterol. They're the particles that carry them are ApoB-related particles. I often have seen that plant-based diets are really impactful for lowering cholesterol, although the data have shown that for lowering LDL and ApoB, it's really about 20 to 25% decrease just with dietary alone. And so for individuals who really need 50 to 60% reduction to get toward their goal, for example, secondary prevention is a good example of that. Really, you need statin therapy or other lowering therapies.
Can you comment on the cost of the coronary calcium imaging?
Sure. At UH, University Hospitals, it's zero. And at other institutions, I don't know, but usually it's between probably $100 to $150, I would guess, in most cases.
And is that typically covered by insurance?
I think it's state dependent. I don't know what the coverage is in Ohio. In Texas, it was not covered by insurance, but most places had it for about $99. So, given the fact that it is probably the best risk test we have beyond the calculator, often it's cost effective to do that testing, certainly more cost effective than other testing that we might do, which is probably even more expensive.
Thank you.
And great presentation, Ian. Thanks, everyone. Back to Claire for a minute, please.
Sure. Thank you, Dr. Neeland, again for being with us this morning. As a reminder to everyone, Cardio's webinar is Wednesday, November 16th at noon. You do need to pre-register, so we can send you the link. Next slide, Rick, please. And then the spring echo clinic is open. We do have some registrations coming in. We would love to have you guys join us again, but you do need to register in order to do so. And then just one new reminder this week, I am going to send you a contact demographic form through RedCap, our database system. If you just fill it out, it'll take you like a minute. It's your phone number, address, stuff like that, just so we have updated records for everyone. I would appreciate it. If you have any questions, feel free to email. Otherwise, we'll see everybody next week.
Thanks, everyone. Have a great day. Bye-bye.
Thank you.